Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant fetal medicine. So today we are going to talk about IVF and a PGD. Okay, so IVF is a technique in which the embryos are being formed in vitro, which is there in the lab, right? Okay, and PGD is the technique by which we look around for any of the genetic abnormalities in the fetuses, in the embryos, which is being formed in the lab. So the PGD can be of three types. PGD-A, which is for aneuploidy, PGD-SR for any structural rearrangements of the chromosomes, and PGD-M for any mutations, right? So basically, whenever the embryos are being formed in the lab, at a 6 cell stage or a 8 cell stage, the embryos are being subjected to a trophectoderm or a cell biopsy, and then a PGD-A usually. So Samanyata in normal circumstances, a PGD-A is being those embryos are being subjected to PGD-A, and then we identify whether the babies are aneuploid or babies are euploid. Whether chromosomally they are normal or they are abnormal. Once we identify that they do have a mosaicism or they are some carrier for any aneuploidies which we identify in the lab. So meaning thereby that the lab gives the recommendations for the embryo transfer, whether they are recommended for transfer or they are not. But then this whole technique, it is not foolproof. So this is, I'll explain you in these slides. Okay, so this shows how the embryos are being subjected to embryo biopsy. Okay, so the biopsy trophectoderm cells. So this could be inner cell mass or a trophectoderm, which can be an aneuploid or euploid. So less than 20%, 20 to 80, or greater than 80%. Now this was one case in which they've identified aneuploidy in both the embryos, and therefore it was not recommended for transfer. Then also the transfer was being done, and then at 16 weeks we identified that the baby is devoid of any chromosomal abnormalities. Okay, the success rate of the pregnancy, whether it is spontaneous or with an IVF, is something around 33%. And then one third of the babies, they do have chromosomal abnormalities. So the chromosomal abnormalities, if they happen naturally, they are bound to happen within IVF pregnancies also. Pehla. So meaning thereby that once the babies are being formed in vitro or in the lab, and then once we test the trophectoderm, so meaning thereby that we have not tested the inner cell mass, which is going to actually form the babies. We usually test the trophectoderms. So and then trophectoderms, they can be mosaic, meaning thereby that the mosaicism can be there, meaning thereby that we can have a mixture of the cells which is normal in chromosomes, or they could be abnormal, right? So depending upon the mosaicism or depending upon the aneuploidy, from 20%, 20 to 80%, or greater than 80%, and therefore we can classify them as euploid, mosaic, and aneuploid, right? This is an entire different issue. But once the baby, like in our case, we have had two embryos in which the PGDA was being done, and therefore the lab has given the red signal, or they had given that probably it is not recommended to go ahead for an embryo transfer. Even then also we went ahead with the embryo transfers, and then we have had one baby landed up in the vanishing, but the second baby survived. And then we did the amniocentesis at 16 weeks, and then we did all the genetic evaluations so as to identify whether the baby is having any chromosomal abnormalities, which it turned out to be negative, right? So how did it happen? So this is I'm going to explain. So meaning thereby that once we do the biopsy, we are usually testing the trophectoderm, which is eventually going to form the placenta, not the inner cell mass. Pehla. Second, there is usually autocorrection which is happening into the baby. So this phenomenon is called as a trisomy rescue, meaning thereby that the cells, whether it is inner cell mass or trophectoderm, which are having some sort of an chromosomal imbalance or deletions, they would die down on their own, and they will not multiply, and then they will not progress it further, and then they will be taken over by euploid and chromosomally normal babies, right? Third, whatever abnormalities that we've identified in the lab is from the trophectoderm cells, okay, which is going to be the part of the placenta, not from the inner cell mass, which actually would the baby would be formed from the inner cell mass, right? So we can have that benefit of doubt and eventually, even if the lab has told us that probably we've identified the chromosomal abnormalities by doing a PGDA, and the lab has given that these embryos are not being recommended for an embryo transfer. Then also we can do an embryo transfer on that pretext, right? That the success rate is only one third. Then we can take the benefit of doubt, meaning thereby that that might even get into a trisomy rescue and can autocorrect on its own, or otherwise, if it doesn't happen, that would be the part of the placenta, not of the baby. And in 4% of the cases, we identify that the baby even eventually might land up having some chromosomal abnormalities. That if that probably we'll look around for 100% by doing an amniocentesis at something around 16 weeks, right? So this is how it is. So even though the PGDA tells you that the babies are aneuploid, then also there is a it is not the end of the road. Probably we can do the embryo transfers with the informed consent, right? This is slightly tricky, but probably I have tried my level best to clear these things out. Okay. Thank you very much for your patient listening.